FlaSH, facilitative learning on advancement in speech and hearing, is one such dream that has become a startling reality. It is the outcome of our integrated family led by our secretary.
We are proud that FlaSH Series 6 too has evolved under a consistent teamwork of our organizing team led by our organizing chairperson, Dr. R. Sundaresan, our organizing secretary, Ms. Anita P.B. Iva, assistant professors of the department, Ms. Bhuvaneshwari K., Mr. Sam A., Mr. Kamalakannan K., lecturer cum clinical supervisor, Sister Vincy, and energetic clinical supervisors, Ms. Pushpa Sarona, Ms. Regina Mary, and energetic young neophytes of Department of Audiology and Speech Language Pathology. It was with such a tireless squad our FlaSH has evolved. Their association with HCC ASLP has not just been a job or a career option, but a mission with a glorious cause that is being accomplished beautifully. I take this opportunity to congratulate each and every member of the HCC ASLP family for their valuable contributions that has made FlaSH into what it is today.
The purpose of FlaSH is to bring together the student clinicians, professionals and researchers to exchange ideas, to hire-in personal career and professional development, and to integrate new protocol with best existing practices.
It gives us a great pride of honor to give a gist of a FlaSH Series 1 conducted on the topic Auditory Evoked Potentials and FlaSH Series 2 on the topic Assessment Protocol for Speech and Language Disorders, integrating new protocols and existing best practices.
FlaSH Series 3 on the topic of assessment and management of voice disorders, integrating theory and clinical practices. FlaSH Series 4 on the topic of vestibular assessment and management. FlaSH Series 5 on the topic of exploring existing and emerging multidisciplinary trends in assessment and management of specific learning disorders. It takes us an immense pleasure to welcome you all for the 6th series of FlaSH on elucidating the diversities in dysphagia, assessment and management. I request the dignitaries, 6th Secretary, Reverend Dr. Sister Annie Xavier, our Chief Guest of the day, Dr. Jawahar Nagasundaram, our Chairperson, Dr. R. Sundaresan Sir, and our Organizing Secretary, Ms. Anita Phoebe Eva, to take their seat on the dais.
A day without prayer is a day without blessing. A life without prayer is a life without power. To begin this auspicious occasion, may I invite the choir to invoke the blessing of the Almighty. Ladies and gentlemen, I request all of you to arise for the prayer.
Heroes and conquer the grave, Jesus conquer the grave. Now I surrender, Savior, He can move the mountain. My God is mighty to save, He is mighty to save. Forever, author of salvation, heroes and conquer the grave, Jesus conquer the grave.
A reading from the letter of St. Paul to the Philippians, chapter 4, verses 4 to 9. Rejoice in the Lord always. Again I will say, rejoice. Let your gentleness be known to everyone. The Lord is near. Do not worry about anything, but in everything by prayer and supplication with thanksgiving, let your requests be made known to God. And the peace of God, which surpasses all understanding, will guard your hearts and your minds in Christ Jesus. Finally, beloved, whatever is true, whatever is honorable, whatever is just, whatever is pure, whatever is pleasing, whatever is commendable, if there is any excellence and if there is anything worthy of praise, think about these things. Keep on doing the things that you have learned and received and heard and seen in me, and the God of peace will be with you. This is the word of God. Thanks be to God.
Dear Lord, we praise you, we adore you, we glorify you. Lord, we seek your mighty presence among us to bless everyone here gathered for the conference. We thank you for giving us the opportunity to gain from this conference and approach each other with kindness. Thank you, Lord, for bringing all professionals and students to this conference. We know that they are here by your plan and mercy. We humbly pray to you, Lord, to bless our secretary, principal, academic coordinator and head of department with your highest blessings so that they guide us and enrich our knowledge. Bless the admin team who have taken great efforts to organize this conference. Embrace the speakers with your Holy Spirit, that their words are comprehensible and we are enlightened by their speech. We lift up ourselves to you, Lord. Strengthen us with your love and mercy, that we practice our profession with what we learned here with compassion. We surrender ourselves to you, Lord. We seek your helping hand to lead us and make this conference a grand success. Shield us and shine on us that we successfully complete this conference without any impediments. In the name of Jesus Christ, Amen.
I invite our organizing secretary of HCC FlaSH Series 6, Ms. Anita Phoebe Eva, to welcome this
small cheer and great welcome make a merry fest. A very pleasant morning to everyone gathered here. If you see it in your mind, you will hold it in your hand. With such a thought, facilitative learning on advancements in speech and hearing, HCC FlaSH Series 6 on elucidating the diversities in dysphagia assessment and management has been evolved and organized meticulously. It is my pleasant duty to bid you all a genuine welcome this morning. Welcome one another as Christ welcomed you for the glory of God. First and foremost, I invoke the presence of Almighty and seek His mighty presence throughout the conference. When the wind blows, some people build walls, others build windmills. And yes, we have such great patron, our Reverend Dr. Sister Annie Xavier, Secretary, Holy Cross College, who supports us throughout our journey and for showering immense love and care towards us. We welcome you, dear sister. Encouraging others is the most insightful gift one can give, for the results of it are lifted spirits, increased self-worth and hopeful future. One such person is our dynamic principal, Reverend Dr. Sister Krishna Bridget, who encourages and guides us in the right pathway and helps us to succeed in all our endeavors. We welcome our dear sister in her absence. A leader inspires others to dream more, learn more, do more and become as one. I extend a pleasant welcome to our enthusiastic academic coordinator, Reverend Dr. Sister Lourdes Mary, who has been an inspiration for all of us to work hard and reach greater height in her absence. To the world, you may be just a teacher, but to your students, you are a hero. It's the supreme art of a teacher to awaken joy in creative expression and knowledge. Yes, our chief guest, Dr. Jawaharlal Nagasundaram, is such a teacher who always ignites us with great knowledge. A hearty welcome to you, sir. Leadership is not about being in charge. It's about caring for those who are in charge of. The team of FlaSH Series 6 is led by our dear sir, Dr. Sundaresan, organizing chairperson who always cares and sets greater goals for us to excel. A grateful welcome to our dear sir. I take this opportunity to gratefully welcome all the eminent speakers of HCC FlaSH Series 6 who has accepted our humble invitation and present here to elucidate the diversities in dysphagia assessment and management. Welcome, dear professionals. It is my pleasant duty to welcome all the professional and student delegates from various places and institutions like Institute of Speech and Hearing, Madras Medical College, School of Rehabilitation and Behavioral Sciences, Arbadeviri Medical College Hospital, Pondicherry, Merck Institute of Speech and Hearing Private Limited, Chennai, Faculty of Audiology and Speech Language Pathology, Sri Ramchandra Institute of Higher Education and Research, Chennai, Dr. S.R. Chandrasekhar Institute of Speech and Hearing, Bangalore, Department of Speech, Hearing and Communication, NITMED, All India Institute of Speech and Hearing, Mysore, Institute of Speech and Hearing, Mahatma College of Special Education, Kasaragod. A fervent welcome to press, media persons, administrative, technical and other supportive staff. And finally, here's a hearty welcome, a big and warm enough to come to the family. As the organizing secretary of 6th series of FlaSH on elucidating the diversities in dysphagia assessment and management, I take immense pleasure in welcoming each and every one of you gathered here for the inaugural function. Thank you.
Thank you, ma'am.
Good morning to all the delegates. It's an immense pleasure for me to deliver the program outline of FlaSH Series 6. FlaSH brings students, professionals and researchers to exchange ideas and develop their career and professional development towards integrated learning. The main motto is diversity in the field of swallowing disorders and to highlight on the recent trends in assessment and management as to strengthen the basic fundamentals, both theoretical and practical knowledge. You guys would have gone through the brochures. The idea is the dysphagia assessment and management is getting updated day to day, and it's our duty to link both theory and clinical practice together. The FlaSH series is not a traditional chalk and talk method. As you are witnessing, you are all into groups. It will focus on active learning strategies, hands-on field session, live demonstrations, case discussion. The program schedule, the day 1 will focus on pediatric dysphagia. The speakers are Dr. Lakshmi Venkatesh, Associate Professor, Sri Ramachandra, Faculty of Audiology and Speech Language Pathology, Chennai. Ms. Arya CJ, Deglutologist, Head and Neck Surgery and Oncology, Amrita Institute of Medical Science, Kochi. PhD Scholar, Ms. Jayaprada G, Sri Ramachandra, Faculty of Audiology and Speech Language Pathology, Chennai. Mr. Faninder Reddy, Speech Therapist, KIMS Hospital, Secunderabad. The day 2 will focus on adult dysphagia. We have expertise, Dr. Vidyadharan, Head and Neck Surgical Oncologist, Tank Institute, Chennai. Mr. Faninder Reddy, Speech Therapist, KIMS Hospital, Secunderabad. Dr. Sapna Ma'am, Professor in Speech Pathology, All India Institute of Speech and Hearing, Mysore. Mr. Prasanna Hegde, Program Director and Clinical Lead and Department of Deglutology and Speech Language Pathology, HCC Cancer Center, Bangalore. Ms. Anju VN, Speech and Swallow Pathologist, Kochi, Kerala. And day 3 will focus on oncodeglutology. We have Dr. Premalata, my teacher, Professor and Department of Speech Language Studies, Dr. S.R. Chandrasekhar Institute of Speech and Hearing, Bangalore. Mr. Prasanna Hegde, Program Director and Clinical Lead, SCG Cancer Center, Bangalore. Ms. Smita, Senior Speech and Swallow Therapist, Narayana Hedalia, Bangalore. Mr. Anik, Speech Therapist, Department of Surgical Oncology, Malabar Cancer Center, Kerala. And we have Swati Lakshmi, Assistant Professor, Department of Clinical Nutrition, Amrita Institute of Medical Science in Kochi. And last, on research point of view, we have Dr. Krishna Kumar Tangappan, Professor and Head and Neck Surgery Oncology from Amrita Institute of Kochi. He will focus on the research opportunities in dysphagia. So all the speakers have been identified by our team and we discussed with senior fellows of our own profession. We want this program as a good learning pitch for you guys to learn about dysphagia and go and practice dysphagia. Thank you. Have a happy learning.
Thank you, sir. Good teachers are the reason why ordinary students dream to do extraordinary things. All the Holy Crossians are proud to have enormous achievements as such. I request our beloved and vibrant Secretary, Holy Cross College, Reverend Dr. Sister Annie Xavier, to deliver the felicitation address.
Respected dignitaries on and off the dais, and student delegates from different states, and here a very warm welcome to all of you. Good morning. This is a program envisaged long ago, but it has happened now, so we believe everything happens and in its own time. And one more reason for it, I think the delay is that God allowed that this has to happen in the centenary year, so it is a centenary event. So happy congratulations to the department. It's my pleasant privilege to be with you and say a few words of felicitation at the inauguration of this meeting, which is going to explore the existing and emerging multidisciplinary trends in educating the diversities in this area. The current scenario in understanding the pathophysiology and applying the mechanism related to this area of study continues to evolve along with the technologies that are used to assess and to make appropriate clinical decisions regarding the intervention techniques for individuals, and it also alerts the need for trained professionals in the field of the study. Despite these increasing demands for professional help, there is a lack of experienced and trained professionals in rehabilitating individuals with this area of study. This, I congratulate at this moment the Department of Audiology and Speech Language Pathology of Holy Cross College for their meticulous planning, arrangement, and also the detailed program charted out for the 3 days. It will be very, very useful and profitable and intellectually organized program for everyone who attends this to these 3 days functions. The organizers have chosen the right topic, and they have also handpicked the best resource persons as to enable a truly knowledge enriching sessions. The enlightening talks delivered here will provide each one of you with possibilities, opportunities, and create new ideas and to enrich this field of study. As for me, I don't consider this as a professional subject. It is a mission mode of relating to people. It is not a profession, it is a mission, because you touch people, you listen to them, you relieve them of this, unlike in the individual attention is given to every person coming to you. This is a speciality I consider, and I appreciate and praise the also this area of study for God's blessings. As for me, though I am not in the area of study, I appreciate their work very much. It is holy profession which we find in the Bible. Jesus touched and healed them. So once again, I wish you all the blessings of God always for these days, and may each one of you acquire good knowledge that will refine professionalism in you, thereby helping you render the best clinical services to your patients. Life is made beautiful by shared moments like this. I can see the eager faces and the heart is unusually full. And wish you all success and God's blessings on behalf of the management, the principal, and all the organizing department. God bless you all.
Dr. Jawahar Nagasundaram, Head, Neck and Throat Surgeon, GVM Hospital, Trichy, as our chief guest for the day. Sir has been a constant positive figure in supporting us through all our endorsements. We welcome you, sir, to enlighten our minds with your thoughtful ideas.
Good morning, all of you. I was amazed by seeing the program here regarding dysphagia and swallowing. It's just a phenomenal program. I would like to thank to the Holy Cross College, Reverend Sister Christina Bridget, Principal, the Secretary, Reverend Sister Zani Xavier, the Department of Audiology and Speech, Dr. Sundaresan. He's known to me for many years, and we are closely associated. I am also a visiting faculty here. I am visiting professor of Holy Cross. I was the faculty at Madras ENT Research Foundation for many years, after which when I came over to Trichy, then Sundaresan invited me to be a part of this institution as well. I would like to thank all the staff members here, and I'd like to, so happy to see Anita sitting on the stage as an organizing secretary. and it gives me a lot of pressure. I don't know whether I've scolded her a lot when I was a teacher to her. Forgive all that, and I'm really proud to see my student here, and I would like to thank all the department staff, Bhuvaneshwari, Sister Vinci, and Pushpa, and I like to see all the department heads from various states, from Mysore, Kerala, Murph, then Ramachandra. It's really amazing to talk in front of you. It is a great opportunity here. When audiology and speech was started, I was part of it at Murph, Madras Research Foundation. The main idea was audiology, and the second one was speech. Nobody even dreamt of swallowing, because swallowing was taken for granted. Nobody brushed aside. Swallowing is, you have to go through the kind of, you just neglect it. Do audiology, do BERA, do all this WEMP, ECOG and all those audiological advanced tests. Then you do the speech, where we introduced the first stroboscopy in Madras Research Foundation, and Dr. Mohan asked me to be the head of the stroboscopy unit as voice, and that was a trend. Then we went into stroboscopy voice and voice issues and all that, and never was swallowing a very major topic, even though there were lots of problems existed with swallowing and dysphagia. But it's really nice, amazing. I think I'm really growing old, because the amount of development has happened in dysphagia and swallowing is never was there part of our curriculum and our studies during our times, and the program for the first day, the second day and the third day is just phenomenal, and you people are very lucky and to know all this. To be very frank with you, as a doctor, I would like to say that most of our ENT surgeons are not very aware of whatever these things are happening, how to handle dysphagia in malignancies, how to handle dysphagia in specially abled child, how to handle dysphagia in these are all needs to be tailor-made. See, that's what I said. Unlike audiology and speech, audiology means you do a pure tone, you do a BERA, you do everything is streamlined. It's all single prototype. You have to just follow the protocol. Same with voice. You have a standard protocol. You do the examination, you do the voice assessment, you do the stroboscopy or video laryngoscopy. You assess the problem. If it's a very simple example, I'll take vocal cord palsy. So immediately we inform the therapist, and then the protocol there ends the whole planning, and then the speech therapist takes over. But unlike in dysphagia and swallowing, every patient is different. Every patient is different. Every patient is unique. You can't do the same protocol for same problem in two different patients. One example I'll tell you, very simple. My close relative has had a motor neuron disease, ascending motor neuron disease, very close relative, I don't want to think. He had started from the leg and then it went upwards. The respiratory muscles got involved, the abdominal muscles got involved. And as usual, the swallowing also got involved. And you won't believe the way the mother was so well trained, my cousin and sister. They used to put him in a particular stage, upright position, head turned towards one odd position, and then they used to give the milk or food. I was wondering, how did she learn that? They all learn by trial and method, and finally the parents and the people who are there are so well trained. And I was amazed seeing an ENT surgeon, and she is a non-medical BCom graduate doing an excellent job as far as dysphagia is concerned, and the child is also eating. That is a kind of changes have taken place, because they identify which part of the pharynx is working, which side of the pharynx is working, which part of the esophagus and the pharynx are coordinating for them to put the milk or the fluid so that that side can be taken. Same way in cases of CA tongue, cancer tongue, we operate and we also think a lot. Recently I operated a 30-year-old lady with CA tongue. We did a hemiglossectomy, and but these things do recur. As far as tongue is concerned, it recurs a lot because tongue drains on both the sides. Unlike the rest of the larynx and other head and neck part, the tongue unfortunately drains on both the sides, and their prognosis is very bad. At one fine stage, she will go in for a total glossectomy. Once a patient goes in for a total glossectomy at the age of 30, what is her future? There is a need for you all to go and help and train her. Professor Jayakumar from Trivandrum used to say, teach us how to deal with such cases. He says, like, tilt the head upwards, use a straw so that the first part of the swallowing is bypassed. So you go into the second part of the swallowing. When the second part of the swallowing is taken over, the first part is what? Bolus formation and then pushing the food backward. That's the first part of the first stage of swallowing. The second stage is the most important stage where the palate has to close, the larynx has to come up, the larynx has to close, the epiglottis has to close. It's a very complex phenomenon. We don't know the value of swallowing at all when we are eating. We just put the food in the mouth and it goes in. But the amount of complex phenomena or the neuromuscular coordination which is involved in first stage and especially in the second stage is just amazing. And the third stage also, it's an involuntary stage, the esophageal stage, where it's involved, the food just goes in as without our knowledge. So all these things have to be studied individually and then have to be treated. Same way I used to see people, can I speak for some more time if you permit, you have time for that? In our Indian culture, when the people are in stroke and in final stages of life, they will be lying down and he will be hardly breathing as well. So what they do is they pour milk. They pour milk and the grandson comes and pours the milk, the father, the son comes and pours, the daughter-in-law comes and pours. You know what happens? He is in stroke, he is in final state, the brain is not functioning, the deglutition is not functioning. Finally they aspirate and die. So unfortunately, these kind of things are assessment and analysis and education is very, very important. See, only dealing with swallowing is not important. Yes, swallowing is important, dysphagia correction is important, but also we should prevent the aspiration part of it. Just by achieving swallowing is not end of the goals. The aspiration should be prevented at any cost. If you are allowing to swallow and the patient is aspirating, that's a death knell. You are wishing him the death and you are he's counting his days. Everything is going into the lungs. Same thing happens when see, giving a rice tube or peg is very, very easy. It takes time, 5 minutes. You make a hole in the stomach, you give a peg, but he should eat, he should relish what is there more than eating. He should relish what he is eating. By eating what, it stimulates your brain, it stimulates your the enzymes in the liver, it stimulates the enzymes in the pancreas, it helps in the digestion. Instead of that, you just bypass what God has given and go to a peg or a rice tube. It doesn't make sense, but there are conditions where you need to give a peg or a rice tube. We are forced to do that. But in case if you are forced to do a peg, in case if you are forced to do a rice tube, plan in such a way how to come out of that. Every patient is different. Every patient is different. When I do a scopy, when patients come to me with dysphagia, when I do a scopy and they say that morning when I had idli, I am not able to swallow for the past 2 weeks. When you look into the throat, when you look into the hypopharynx, you will have a huge tumor. I will be wondering how this man is eating idli and milk and all that. There will be only a tiny hairline opening which he will be managing. But some patient will come and tell me that, sir, I am not able to eat at all. When you look into his throat or the larynx, it will be perfectly normal. But don't brand the patient as psychologically into no. There is a muscle in coordination is happening. Baby man used to say that always when you have voice issues, you have dysphagia also. I used to think why ma'am says that. Because voice, the nerves are the 10th cranial, 9th, the 10th cranial nerve. The same nerve helps for the swallowing as well. So when there is a spasmodic dysphonia, when there is a spasm, everything, it goes into the larynx as well as it goes into the esophagus and pharynx because it's same nerve innervation. So when you have a voice problem, what is voice basically? It is your emotional system. It is your limbic system which controls. When you cry, you use your voice. When you sing, you use your voice. When you are angry, when you shout at somebody, you use your voice. All the emotions are controlled by the limbic system. So when the voice is also, you will see patients talking from the throat. All of them are stressed out. This is a stressed out environment. People will be talking with severe spasm in the larynx. And once, not only larynx, it also involves the pharynx. Another interesting case, I'll tell you how dysphagia plays a very important role. Last week I had a patient who had undergone a total laryngectomy and he had a voice prosthesis. This laryngectomy was done at Madras ENT Research Foundation about 11 years back by me and Mohan sir. That patient had laryngectomy and we inserted voice process. He was very happy. Suddenly he came to me 2 weeks back saying that he was unable to swallow at all. Then we did a scopy, we found a huge tumor there. So the tumor was above this is the second primary, above the voice processes. So what to do? So finally I explained to the patient, sir, I'm sorry, I have to remove the voice processes. I removed the voice processes and I introduced the right tube to the tracheoesophageal fistula, the TEP which is done for the voice process. So how to handle dysphagia, every patient is different. You have to sit and think and then do it. Thank you for giving me the opportunity. Thank you very much. Have a wonderful day.
What we are at this moment.
College is, this is your centennial year. Way back in 1923, with few girls, this institution was started. Now we have around close to 6,000 girl students studying in this. Our college is the first institution to offer women education exclusively in audiology course. We have the pride that we started this. We have a lot of first graduates who are studying in our institution who are successfully running their clinics. We help them to run their clinics also, and we even support if they are into sports for free education. So it's an important moment. On all these 3 days of FlaSH, we will be felicitating our own professionals, women who have been successful in our profession. So today we are giving the appreciation for Clinical Excellence Award in the field of speech language pathology to Dr. Lakshmi Venkatesh. Dr. Lakshmi Venkatesh is currently working as Associate Professor at Sri Ramachandra Faculty of Audiology and Speech Language Pathology, Chennai. Madam also holds the position of Assistant Dean of Students of Faculty of Allied Health Science at Ramachandra University. She also has obtained a UG degree in Speech and Hearing from Alivarjong National Institute of Speech and Hearing, Mumbai in 1999. PG degree in Speech and Hearing from All India Institute of Speech and Hearing, Mysore. PhD in Speech and Hearing Sciences from University of Washington, USA in 2007. And a PG Diploma in Bioethics from National Institute of Epidemiology, Chennai in 2015. She has a teaching, clinical and research career spanning 20 years. Her current area of clinical and research interest include feeding and swallowing disorders and child speech and language disorders. She is involved with intervention for feeding and swallowing disorders across the lifespan from neonates to elderly at Sri Ramachandra Medical Center and Sri Ramachandra Hospital. Ma'am has completed several funded projects and has been awarded and recognized at several national, international university and scientific forum. She is also HANN certified. She served as the Executive Committee member of Indian Speech and Hearing Association from 2010 to 2012. Joint Secretary for Indian Speech and Hearing Association from 2012 to 2015. She is a visiting expert for our Inspection of Speech and Hearing Training Program in India since 2014, conducted by Rehabilitation Council of India, Government of India. Ma'am has rendered a service as an associate editor of Journal of Indian Speech and Hearing Association 2009 to 2012 and currently as a reviewer in the following journals: Journal of All India Institute of Speech and Hearing, Journal of Indian Speech and Language and Hearing Association, Journal of Acoustical Society of India, Sri Ramachandra Journal of Medicine. She is a life member of Indian Speech and Hearing Association, Acoustical Society of India, Madras Regional Chapter of Acoustical Society of India, Dravidian Linguistic Association, Aish Alumni Association, Life Associate Member of Indian Association of Clinical Psychologists. Ma'am has more than 13 peer-reviewed publications in journals in the last 10 years and also has written a few book chapters and full paper in proceeding and monograph. Wishing her success in all the future endeavors awarded during the HCC FlaSH Series 6. Thank you.
I kindly request all our staffs to join them on the dais.
And a very pleasant one. I'm humbled, deeply humbled and grateful for this honor. I don't know if I truly deserve it because my journey has just begun in this field and I have a long way to go, I believe. But I'm extremely grateful. I'd like to thank Sister Annie, Dr. And Sundareshan, of course, for this honor. I think this page has a passion for me and I have tried my best to share my knowledge. And it is, as Sir has said, it is a great area and I hope we'll all have a great time learning. We are also constantly learning in this area and we are evolving. This field is evolving every day and we are constantly learning. So I hope we'll all have a great learning experience in the next 3 days. Thank you again very, very much for this honor. It's very special because as you said, it's your 100th year. So it's a very special year for you and I'm grateful for this honor on your special centenary year. Thank you so much.
I want a clinical supervisor, Ms. Pushpa Sarona, to thank the gathering.
Gratitude can transform common days into thanksgiving, turns routine jobs into joy, and change ordinary opportunities into blessings. The warmth of privilege fills my heart for this opportunity to propose the oath of thanks to this august gathering. Let me start by thanking the Almighty God for this great day and for the gathering of FlaSH. My affable thanks to our special chief guest, Dr. Javagar Nagasundaram, Head, Neck and Throat Surgeon, GVM Hospital, Trichy, who despite of his busy schedule, has found time to grace this occasion. Thank you, sir. I would like to extend this note of gratitude to the pillars of Holy Cross family comprising our ebullient secretary, Dr. Sister Annie Xavier, our beloved principal, Dr. Sister Christina Bridget, in her absence. Thank you, sister. A special note of thanks to our vice principal, Dr. Sister Isabella Rajakumari, our exuberant controller of examination, Reverend Sister Lizzie George, our statutes, vice principals, deans and heads of various departments for their uphold and earnest guidance. I genuinely thank Reverend Dr. Sister Lourdes Mary, Academic Coordinator, Department of Audiology and Speech Language Pathology, in her absence, and our head of the department, Dr. R. Sundaresan, for their motivation and enthusiastic support. A dream doesn't come reality through magic. It takes sweat, hard work and determination. FlaSH series is one such dream that has become a stupendous reality which is the outcome of our integrated family led by our organizing committee members. I can't thank everyone enough for making this dream come true. My heartfelt gratitude to professionals, staff and students of other colleges, including Institute of Speech and Hearing, Madras Medical College, Chennai, School of Rehabilitation and Behavioral Sciences, Arupadeveedu Medical College and Hospital, Puducherry, Murphy Institute of Speech and Hearing, Chennai, Sri Ramachandra Institute of Higher Education and Research, Chennai, Dr. S.R. Chandrasekhar Institute of Speech and Hearing, Bengaluru, Nirmad, Chennai, Institute of Speech and Hearing, Marthoma College of Special Education, Kasaragod, All India Institute of Speech and Hearing, Mysuru, and SRM Medical College, Hospital and Research Center, Chennai, for giving us such a recognition. This whole platform wouldn't have been of this outthrough without our technical team. Sincere thanks to you all. Moments are made to memories and cherished only when they are captured. Thank you, media, for giving us such those precious moments. Last but not the least, I thank our little superstars for this cordial input and honest work. Once again, I thank you all.
As we express our gratitude, we must never forget that the highest appreciation is not to utter words but to live by them. Thank you, ma'am.
Okay, so let's get started. The topic given to me was exordium. I had to really look up the meaning. So I'd like to first congratulate Sundareshan and team for putting such exotic topics. I think that does motivate the speaker and the audience. Okay, so exordium means introduction. Okay, so my task here is to set the stage for what is pediatric dysphagia, and you can put up as many red cards as you want so that I know that you have not understood. Okay, so I will try I was given an hour. I don't know how much time I have now since we are running late, but you can tell me how much whenever you want me to go fast or something. Okay, so I will try and set the stage for what is pediatric dysphagia and what do we mean by feeding disorders and swallowing disorders. Okay, so yeah, just briefly. So I just want to show you this, my journey in pediatric dysphagia, to kind of tell you the different setups that can be there in the field of pediatric dysphagia. So I graduated from Aish, and then my first job was at Spastic Society of Tamil Nadu, where I was exposed to dysphagia. And that's where I started working with children with cerebral palsy who were having dysphagia, and we learned on the job. So that is a kind of a setup which is a specialized rehab center, school or an early intervention center. Then I went on to do my PhD, and there I did a lot of coursework in pediatric dysphagia and med-SLP. I wasn't really handling too many patients, I only observed patients. I worked at Sweetcar where I was working, there were several child development units. That's where I was introduced to the concept of a child development unit led by a developmental pediatrician. And there also I saw a lot of work, and I did a lot of work in dysphagia with children. Then I worked at ISH where we did mostly OPD work in dysphagia. And then I moved, in the past 9 years I've been at Ramachandra where we have a variety of setups for pediatric dysphagia. We work at in the hospital, we work in the NICU, Neonatal Intensive Care Unit. We work in the Pediatric Intensive Care Unit, NICU, PICU. Acute care, so immediately after discharge, after discharge from PICU, they come into the ward, and that's called acute care. And we also get children in the OPD. So a hospital gives us a lot of these kind of setups. We also have a child development unit at the hospital, which is led by the developmental pediatrician again, where all the NICU graduates are enrolled. So all children who
who pass out from the NICU, pass out means who come out of the NICU, get enrolled into a child development unit, and they are followed up regularly for neurodevelopment. That is again a place where we do a lot of swallowing work with children. We have an early intervention center at Ramachandra, where we have like a special school kind of a center for birth to 6 years. That is also a place where we do a lot of children work. So just to give you an idea of where all pediatric dysphagia can be there. So it's not necessary that it's only in a hospital. There are multiple setups where you can see children with dysphagia. Okay. So in the next 45 minutes or an hour, I'll try to reduce the time so that we can catch up on the time. I will try and explain to you is what is feeding and swallowing, are they same? Why do we have feeding disorders and swallowing disorders? I'll try and cover the etiologies little bit so that you know what kind of children really have pediatric dysphagia. And I'll try and help you identify children with feeding and swallowing disorders. So just go into a little bit of signs and symptoms. So I understand we have a very diverse group here. We have students from first year BASLP to practicing speech language pathologists. So I kind of try to tailor this talk for first year, second year, third year students, interns, PGs and professionals. So I apologize if it seems too simple sometimes or too difficult sometimes, but I've tried to kind of make it so that there's something for everybody, okay? And I'm always here, I'm here the whole day, so if you like to talk, we can always talk. Okay. Oh, this is going to be hard. Can you play the video, JP? Audio? Will audio come? Doesn't matter. So just pay attention to this video. Just see what's happening. This was just a child who came into OPD. I'm not giving you any detail. Just observe what's happening, right? And just think for yourself what's happening. Just yourself, what's happening. We just saw this child. This child was sent to us for speech and language assessment. And the child was hungry, so I said, why don't you feed the child in front of us? That's all was the instruction. We saw the mother and the father holding the baby and feeding the baby. Okay? So I just want you to see what's happening. If you had audio, you would see the child crying also. But you just see what's happening, right? The baby is taking something in. Do you want to play it once more, JP? Okay, and they're feeding the child some rice kanji, rice powder cooked in. Okay, so something is going in, something is not going in, something is coming out. So there's a lot of things you see in this video. It's not the most ideal situation. There's something going on, right? Something going on. Okay. Next slide. Let's go to the next slide. So we'll try and see some more videos. So let's just look at what is difference between feeding and swallowing. Okay. So feeding is the process really of taking the food into the oral cavity. In this case, the mother was feeding the child. When we eat, we self-feed ourselves. Children also self-feed. So we take the food and we take it into the oral cavity. And the whole feeding is very important for speech language pathologists because it provides children and caregivers with opportunities for communication, for social experiences, interaction and all that. Swallowing, on the other hand, we refer to it as the process of deglutition. I can see there are some deglutologists in the crowd also. It's considered, there's a word called deglutition and it occurs after the food or liquid enters the mouth. Okay, so we refer to that as swallowing. Okay, and just this one slide on what are the phases of swallowing, right? So food is entered into the mouth, then we typically refer to swallowing as having 3 phases. So the oral phase, which includes making the bolus, oral preparatory phase. Then we have an oral transport phase where the bolus is pushed back. And then we have pharyngeal phase, which is a very important phase, as Dr. Jawahar was saying. So much happening during the pharyngeal phase where the pharyngeal constrictors are moving the bolus down, all the way down, the larynx is elevating, the pharyngeal port closes, so much, that's the most important phase. And then it goes to the upper esophageal sphincter, which is the opening to the esophagus, and then the food enters into the esophagus. Then there is something called the esophageal peristalsis, the movement of the esophagus, which pushes the food down all the way to the lower esophageal sphincter, which is the opening of the stomach. So This deglutition itself is a big process. So food enters the mouth, then oral phase, pharyngeal phase, and then down to esophageal phase. Okay, now this is same for children and adults, but the anatomy and physiology is slightly different for children from adults. Next slide. So in feeding, when we are talking about children, I already told you the difference between feeding and swallowing. There's another thing to think about is breathing or respiration. So in infants, in adults as well, but there are three things really happening. There is this feeding, then there is swallowing, and at the same time we have to keep breathing. Right? So when we swallow for a brief time, the respiration is stopped, we swallow, and then we again start. So there is this interconnection between all the three, and all the three should go on well in order for us to be feeding well. So when do we say a child is successfully feeding? Let's see that first, right? So that for us to know what goes wrong, right? When do we say successfully child is feeding, right? Normal feeding, oral feeding. Now that needs, so there's a child there taking food from the spoon nicely from the cup and eating, right? So we say successful oral feeding. So it requires that there should be a good sensory motor system, there should be good swallowing skills here, and the overall health of the child should be good. They should not have any respiratory pulmonary problems or gastroesophageal intestinal function problem. The central nervous system, like every other skill, swallowing is also a sensory motor skill, so there should be good CNS integration, brain functioning, right? Central nervous system integration, and the musculoskeletal tone should also be adequate. So all of these are needed for successful oral feeding. And how do we measure successful feeding? How do we know that a baby is feeding well? When the baby is growing, right? When an infant or child is growing. If there is adequate growth, everybody is happy, right? The mother is very happy when the child is gaining weight, right? All well, growth, that's what the mother wants, right? So adequate growth, which is what is measured by head circumference, weight of the baby and all that, right? And another good mode of measure of successful feeding is, if everything is going right in the development, is if the child is able to eat by themselves. So I consider self-feeding to be a very important measure of successful feeding. Okay. Next slide. So when does the successful feeding happen, right? So around 12 months, right? Development. Can you see the baby, right? We all are familiar with this. Motor milestones are developing, from birth to 1 year of age. So by 1 year of age, we have a fully walking child, exploring everything at this age and even exploring food. So by 1 year of age, we must typically have a child eat most of the same food as adults. Right? This is great, right? By 1 year, a child should be eating most of the food that we make in the house for adults. Does it happen really? Maybe not, right? Maybe little delayed, right? Yeah, because we are we are very protective, right? So we continue to delay things, but technically it should happen by 12 months, okay? And should be able to use all of utensils also if we use it in the house. So next slide. So there are some things, there are some transitions that happen in feeding, which Ms. Arya will, I think, take it up in the next talk. So there is a lot of development that's happening in feeding, but I'll just touch on the main transitions. Initially, the baby is having only liquid, which is food, which is the main food, that is milk, right? A major transition point happens at 6 months of age when we transition from liquid consistency to semi-solid consistency or puree consistency. So people will give kanji, kebamo kanji, cerelac, rice nicely mashed, carrot mashed. Different families will give different kind of food, but a transition happens at around 6 months of age. Then you have another transition happening to more and more thicker and thicker consistencies, and as they say here, by 12 months or let's say 12 to 18 months, you expect the child to have all consistencies, and lot of development is happening in the oromotor skills also, which make the child to have all consistencies. So there is development of reflexes, the movement, the feeding moves from suckle to a sucking kind of a pattern. The tongue movement, which is more anterior posterior in the beginning, then tongue movements becomes up and down vertical movements, and all of this leads to the child having by 12 to 18 months having all textures of food. And actually by 12 to 18 months there is also more independence for feeding. The child actually has motor control to pick up the food and put it in their mouth also, right? But however, next slide, it's possible, next it's possible that there are several cultural factors and parental perspectives, right? So we may continue to not allow the child to really eat on their own. Mothers will continue to feed, right? You would have experienced it in your own families or elsewhere. I think it's an Indian thing that we will give the food, right? So those are cultural things. So the child self-feeding may get a little delayed, but definitely we want the child to be self-feeding at least by 2 to 3 years, because the child has to go to a preschool, a balwadi or anything, right? And in balwadi, wherever they go, they'll take a tiffin box and go, right? And they should be able to eat from their tiffin box. So let's say that in our Indian context, we typically encourage self-feeding by about 2 to 3 years of age. Is that okay? So we have to remember that what happens in the West need not be the same happening in our country. So I'm trying to alert you all that whatever you read in the book, right, they will say that, previous slide, so they will say that cup drinking happens at 11 months or 1.5 years. It may not happen here, we may get delayed a little bit. There is a little bit of, here they say this kind of an open, closed cup. Not all families in India will have a closed cup, so they may just drink from a tumbler or a glass, right? So there are cultural and specifically parental perspectives that also have to be kept in mind. But normally, typically, this should be attained. By 2 to 3 years, we want the child to be successfully eating by themselves and eating all consistencies of food. So whatever is made at home, idli, dosa, puri, chapati, whatever you make for mother and father, the child should be able to eat. This is typically what we expect in normal developmental perspective. Okay? But what can go wrong, right? What can go wrong? So this is a very busy slide. It's there only to give an idea of what all can go wrong. Okay, now there can be several etiologies, several conditions where feeding may not happen like this. Developmentally it may not happen. Many conditions where it may not happen. It is important for us to be aware of that. Okay, so I've just given I'll just read the headings out. So prematurity or children who are born less than 40 weeks. So typically normal gestation is 37 to 40 weeks of gestation. If a baby is born before that, there can be delay. Then there are a lot of respiratory and cardiac disorders that the child may be born with, in which case also there can be some delay. Gastrointestinal disorders. Many of these happen at birth. Some at least necrotizing enterocolitis, some of these conditions happen at birth. These conditions will make the child to have a delay in feeding. Neurological conditions, I think we are all familiar with cerebral palsy. So, cerebral palsy is a neurological condition, and that's one condition where we can have delay. Then we've got congenital anomalies, any kind of an injury. And this is another category. If the child was having tube feeding, tracheostomy, or was in a neonatal intensive care unit, that child can also present with feeding difficulty. We'll look at some of these in little bit of a detail. So let's look at, this is another way of looking at the etiologies. You can look at the etiologies as abnormal neural function, abnormal structural foundation. You can also look at it as non-organic or failure to thrive. We look at this in some detail. And cognitive and behavioral limitations. So, all these kind of children will have difficulties in developing feeding. So, let's go to the first one, abnormal neural foundation. Okay, so we are mainly going to talk about prematurity here. And any kind of a neurological condition which affects the CNS, central nervous system, peripheral nervous system. So something similar to what we know about childhood dysarthria, right? You've all been reading about childhood dysarthria, so something similar to that. All these conditions, if a child is at risk to have childhood dysarthria, it's likely to have the difficulty in feeding also, because similar kind of a system is affected. So what is premature? This is a very important thing to remember, because this is one of the largest reasons why a child starts having feeding problems from the beginning. Okay. So if a baby is born less than 32 weeks of 37 weeks, then the previous slide, the baby is this is a NICU, in neonatal intensive care unit. We have two talks about NICU itself next. So this is where the child is kept in, child is under ventilation and lot of things, and then the child comes out of NICU. So the premature infant is very different from a full-term infant. Even though the child is born early, it's not that the child just catches up after 3 to 4 weeks. The premature infant typically has lot of differences from a full-term infant. Premature infant will not have head, neck, trunk stability, will have an extensor kind of a pattern. So the hands and legs will go into extension instead of a flexion, right? The premature infant will typically have some hypotonia, and the premature infant will not be able to process stimuli from the environment. Whereas a term infant comes ready with all this when the term infant is born. So physiologically they'll have flexion, they'll have normal muscle tone. So all of these things that go wrong places a child at risk for dysphagia also. Okay, so let's see if the video plays. So this is just to give you an idea of a NICU setup, and you have an infant here. There's a speech therapist who's standing on the side. There's a nurse who's feeding the baby, and if you see the child, right, child is going into extension. Legs are going straight like that. Hands are also going straight like that. Child is in extension, and then they somehow try and get the child into flexion, but the child is still going into extension. The speech therapist is actually checking for reflexes, which we look in the knee. Is it moving for all of you? Okay. So you just see the videos as it goes, I'll talk. So the nurse is feeding through a Pathology milk, and we are seeing how the baby is taking the milk, and the baby actually, you can see some bubbles there, and that bubbles indicates that the tongue is actually moving front and back, and that is what is causing that kind of bubbles as the Pathology milk goes inside, and that is the suckle kind of movement. So the baby is having some suckle. If we had audio, the nurse would be very surprised. Oh, the baby is taking. The nurse says something like, "Nalla irukane," he was not taking before, but now he is taking well. And now the infant neonate is awake. Look, he opened his eyes, and now you can see a close up. And once in a while, you'll see the tongue coming out and closing. Once in a while, very closely, if you see, the tongue will come out and close. Not always. It's not very active suckle, but there is some suckling movement. Next. So this infant is just learning to have Pathology feeding. Okay, so having this oral feeding can be delayed in a premature infant. So premature infant takes more time to have this oral feed through a Pathology and then go on to breastfeeding. Any other etiology, any other damage to the central nervous system, peripheral nervous system, including genetic disorders, metabolic disorders, all of these can lead to risk for dysphagia. It's important for us to know that these conditions will have risk for dysphagia. Next slide. So this is again not for you to read, but it's just a busy slide that shows you that there can be several conditions that affect the central nervous system, traumatic brain injury, brain stem injuries, just so many syndromes, including Down syndrome, Rayleigh syndrome, so many syndromes and so many other conditions of the peripheral nervous system. So anywhere you see, if you know in the notes that this child has a condition which can be congenital or acquired, there is going to be risk to the swallowing mechanism and feeding mechanism. Okay, so now let's go to cerebral palsy, right? Cerebral palsy is something we're all familiar with. What happens in cerebral palsy? The biggest problem that happens in cerebral palsy is subsystems of speech are affected. We know that respiration, phonation, resonation, articulation is affected. But another thing that could go wrong in cerebral palsy is this incoordination between respiration and swallowing. Because of this incoordination, they will have feeding problems typically from the beginning. There can be sensitivity to touch and food. There can be hypotonicity, and so as I said, infants are beginning with a suckle, and then the suckling pattern becomes a sucking pattern where the tongue moves up. In cerebral palsy, we all know that the primitive reflexes get prolonged. They don't go away. They're supposed to go away, right? Rooting reflex is supposed to go away. Suckle has to become a sucking response. So in cerebral palsy, there's prolongation of the oral reflexes. So because of this, developmentally, the infant is not able to go to mature patterns of feeding, mature patterns of swallowing. So because the system is not allowing it, the infant will also not be able to take in mature patterns, right? So there is an oral sensory motor dysfunction or delay in 90% of children with cerebral palsy. Just to say that most children with cerebral palsy have some difficulty here, and that places them at risk for swallowing problems. Next slide. Let's see if this plays. So this was a child with cerebral palsy again who came to our OPD, and we're just seeing the, so again and again I want you to look at two components. One is how the mother is feeding, there is that aspect. The other aspect is how is the baby swallowing or taking the food after it goes to the mouth. So if you see here, right, she's showing some tongue movements. Tongue movements are there, they may not be normal. The mother is pouring the food from the spoon, she's pouring it into the mouth. Is the child able to make a lip seal and take the food inside? We have to look at these things. And then she's coughing sometimes. These are abnormal tongue movements. As I said, no, such a big child should not have this kind of movement. Anterior posterior movement is a suckle kind of a movement. This should not be there. For an older child, we should see more up and down, vertical kind of movements. But this child is continuing to show a lot of anterior posterior movement. She's not, at this point, she's not able to hold the lips over the spoon and take the food. Let's go to the next one, next video. We just did, during the OPD itself, we did one small modification. We just made the position of the child better. Okay? Just immediately we made the position of the child better, and see whether you can appreciate the change in the child's oral movements suddenly. Okay? And we are telling the mother, wait. Let the child wait. See, do you see the change in the child's tongue movements? And how the child is trying to close the mouth over the lips and take from the spoon. Not much is now coming out because the child is just after a few minutes. We just did one small thing. We tried to make. So I want you to appreciate how the feeding practice can affect the development of the movement patterns also. So invariably what happens in these children is that they are used to one form of feeding, which may not be the right form, and because of that also the oral motor patterns necessarily do not develop the right way, because they are used to this where the mother just pours into the mouth and the child has to just push the food inside. The child is never learning to close the lips around the mouth and take the food in, so even the oral motor patterns get affected. I think this was another, so we just tried to fix the position and we saw a lot of change. Let's go to the next. Next slide. So this is important, that gross motor is affecting the oromotor dysfunction in this case. And this is very, very important because fine graded movements of the lips and cheeks and tongue happen based on gross motor foundations. So if you are able to hold the head upright and in the midline, if the head goes here, then goes here, it's not midline. If the head is in the midline and the shoulder stability is there, okay, and there is postural stability so that the trunk also remains upright, okay, and there is pelvic stability here. So these are all important gross motor functioning. If these functions are adequate, then that will also help develop fine graded movement. So I want you to understand how in cerebral palsy things go wrong with feeding. It's not necessarily that all the problem is because of this. The problem is because of other gross motor function, and that also tells you that it is easy to change it. We can actually change the feeding pattern by fixing some other things, right? And then move to the fine motor, fine graded movements. Next. So the next set of big etiology is the abnormal structural function. Okay, and in this if you think of cleft lip and palate, you will realize what I am talking about. So everybody is aware of cleft lip and palate. So there is that cleft in the lip and palate or both, and that will definitely affect swallowing because the food is going to come through the nasopharyngeal nasal cavity and the baby does not learn how to make a lip seal. So children with cleft lip and palate are another group that we really observe in the neonatal intensive care unit because they are not able to take to breastfeeding immediately. They really need some special help with feeding. Okay. So this is a big lot. So there is a big category of anatomic abnormalities of the larynx and trachea. And I want to talk about laryngomalacia and laryngeal cleft. So typically what happens is when these congenital conditions happen, child's breathing gets affected because we are talking of larynx, right? So typically a baby will have stridor, difficulty in breathing. So that will be the first sign, along with of course difficulty taking in milk or feeding. But that will get picked up by the doctor quickly because they will see stridor. Anything wrong with breathing, the doctors will pick up first in NICU. And they will go look and see why there is stridor happening. They will do an assessment immediately. They'll try to fix the stridor. That is a red alert for them. Feeding is not the first alert. Breathing is the first alert because that is needed for life, right? So breathing. So they will immediately do a scopy, or they will, as they suspect, they will do a radiological investigation or a scopy, and they detect these structure functions. And so mostly we will know these things because they have also thought about these, and they kind of help us identify whether there is anything or not. But sometimes it may not get identified. We've seen cases like that, whom then we have to go and ask the ENT, do you think there could be something going wrong in the larynx? So we have to be aware that these conditions also lead to dysphagia or swallowing difficulty. The next set of major conditions are non-organic. I want to talk about this because these conditions have feeding problem in the absence of medical motor deficits. So typically what happens is if the infant or a child has had aggressive serious medical conditions. So let's say there was some medical condition that required a surgery when the baby was in the NICU. If there was a surgical intervention done, if the child was in the NICU for a long time for some other surgeries or some other health problem, then it is possible that the medical condition is resolved, but the child presents with sensory based feeding problems. So this is another big category that we see in NICU and beyond. Next slide. So who are the children who come under this category? So these are children who have had some respiratory problem or some cardiac problem who have had to be treated. They may have abnormal sensory systems. They have had to have ventilation, suctioning, they've had to, instruments were put in the mouth, or they were on gavage feeding or oral, there was an orogastric tube for feeding. So typically for babies, they prefer an orogastric tube than a nasogastric tube. We can talk about it when we go to the NICU talk. But gavage feeding means feeding through the orogastric, nasogastric, naso to the stomach, orogastric, oral to the stomach, and PEG tube, right? So percutaneous gastro here, so directly to the stomach. These are all referred to as gavage feeding. So if the baby has had this kind of feeding in the NICU, maybe now it is removed, that baby will have a lot of negative experience because the baby was never oral fed, and these things would cause negative experience, and these children will also present with feeding problems. So this is because of, okay, let's play the video and I'll keep talking. I actually wanted to play somewhere ahead, so just play the video and I'll keep talking. Okay, so this is a baby actually having a PEG tube. Okay, the child is about 2 years of age. The child moved from the US. The child was having a PEG tube. Child is not being fed through the PEG tube for the past 6 months. They have kind of started feeding orally, but you will see now that this is how they are feeding the child. So the mother is coming from behind and trying to give through that spoon. I just told them feed like how you normally feed. Okay, and you will see that the child has only that one consistency of food, and if she brings it from the front, the child doesn't like it at all. But even when she brings it like this, right, you will see a lot of oral aversion. Lot of, child will move away from the food, and then she'll somehow try to put the food inside. She will use this size spoon only. This is the mother, as Dr. Jawahar was saying, they will figure out their own compensation. So the mother has figured out this. So this baby has a PEG tube now, but has been taking food orally for the past 6 months, but this is all the baby can have, this consistency, and like this through the spoon and from the back. Now this is a problem. This problem is there because of the oral aversion and not being able to have multiple consistencies of food. Next slide. So this kind of a thing is important for you to understand. Oral aversions and oral sensitivity problems, right? Now this kind of problems are typically referred to as sensory based problem when the physiology may be normal. Okay, so there may not be much wrong with the system, but the child may present with this. So this happens in children who have had repeated oral invasive procedure. That means they've had oral gastric tube put in too much in the past because they had to have some surgery or something in the NICU. They've had some cardiac defects because of which again they must have been fed through orogastric tube. Autism children. So I want to highlight this because a lot of children with autism spectrum disorder will also present with oral aversions and oral sensitivity, likely because it being a sensory based problem and not necessarily a physiological or motor system kind of a problem. If they had delayed introduction of oral feeding, so if they were having children who were in the NICU, who were having an orogastric tube and who were not fed orally until quite some time. So like this child we saw was on PEG tube till 18 months, then only they started introducing oral feed. So even delayed introduction of oral feed itself can cause sensory kind of problem, these oral eversions, oral selectivity problems. So they can eat only one consistency of food, not all consistencies of food. So it's important to be aware that these both kinds of problems are there. There are sensory based problems and motor based problems. And sometimes both go together in conditions like cerebral palsy. You will have both motor problems and sensory problems. So it's important for us to kind of understand where these problems are and which is more, which is less. Okay, so some examples of sensory based problem. When do you start suspecting it is a sensory based problem? Where if the child is being bottle fed, the child will prefer only one type of nipple, has nipple confusion. If you change the nipple type, the child will not be able to take milk. The child may feed best when sleeping, but when it is waking up, the child will not want to feed because then he becomes more aware of his senses. The child may non-intuitively, he'll be doing nice thumb sucking, but when you give, through the utensil or through, the child may not suck. The child may not like others touching their face, touching their mouth anywhere, prefers liquids. They chew the solid but hold it in the mouth without swallowing. So these are things to really ask for, and this indicates sensory based problems. The child will gag immediately when eating solids or when there's spoon. So if the spoon touches itself, they'll gag. They'll have the sensitivity, oral selectivity, aversion. Okay, so but the same child when distracted may be able to have multiple textures. So this is a picture that is important to be aware of. So this child came to us as a child with suspected autism actually, and again it was not necessarily referred for feeding, and we were just assessing, and again we told them feed the child in front of us, right? And you can see the mother is feeding rice, okay, and it's just plain rice. She says he has milk or he has only this plain rice. He doesn't like anything put in the rice, and this is all that he has. Okay, and you can see that. And then I said, how do you feed? This is how we feed. One person holds, one person gives, or I hold tightly and I somehow feed. So mothers have this mission, right? Mission. It's like they have to accomplish the mission of feeding, right? Which is not bad, which is not wrong at all. That is what they want to do for their child. They want their child to gain weight. So many times feeding happens like this. So then I said, why don't you just give the child the bowl? Then they said, no, he'll spill. I said, doesn't matter, let him hold the bowl and see. Then when he touched the bowl, he was still okay to have the food go inside the child's mouth. And he's chewing, but he's holding in his mouth, right? Whereas the same, he's holding in his mouth, he's chewing, but he's not really pushing it back, he's holding in the mouth. Let's play the next video. Okay, so again here, somehow she gets the food inside, and we will see a little more closer. We see he's still holding the food in the mouth, and it's not really gone in. But this is how she feeds the child. This is, and sometimes unless we ask them about feeding, they will not tell us these things. Sometimes this is not their main concern sometimes. So we have to ask this to the parent. What about feeding? What's happening with feeding? So when I used to work in Spastic Society, this is a side remark. I used to always think, parents used to say, first the child should walk, madam, then I'll come for speech therapy. They will say physiotherapy is very important. They'll go to physiotherapist, then I'll say, why are you not coming? They say, no, I thought my child should walk first, then I should come for speech therapy. Right? Then I used to think, then I used to go and talk to my physiotherapist friends and say, no, if any child comes, send them to me. It's very important that they should do speech therapy also, right? So then I started realizing that physiotherapy, then speech, then only sometimes they tell about swallowing, right? Because they are like, he's eating, I'm giving, it's difficult, but I'm giving, somehow he eats, right? They don't know that their child has to self-feed. So as I said, that's why I consider self-feeding as a measure of feeding, measure of successful feeding, right? Parents many times don't know. So Jayaprada and myself we have an early intervention center. We have about 60 children coming, right? And we just did a survey and we asked the parents what is the difficulty you're having. And they said, yeah, he's eating, I give him this consistency, he has this. Then when we asked about self-feeding, many children will have things like biscuit or something, they will eat that. They will eat something if you give muruk or something like that also. But they won't eat food by themselves. Right? Their parents will say that he self-feeds some food when I give him cup, but he won't eat rice. 6-year-old, 7-year-old children, they'll say, no, he doesn't take rice, he doesn't take chapati, he doesn't take dosa, but he eats something else. So, self-feeding, by that we mean all consistencies of food to be able to self-feed themselves. So, that should be your benchmark. Okay? And anything less than that, your antennas should rise up and say that there is something going wrong. There is a feeding problem or a swallowing problem. Let me check what's going on. So to me, that is the benchmark for deciding whether there is feeding or swallowing problem. So in this case, next point. So as I said, right, so feeding disorder, when we say feeding disorder, it refers to inappropriate development of oral intake. So if they are not able to take orally on their own, there is something wrong. So that is your feeding disorder, whereas a swallowing disorder is difficulty in eating as a result of physiological or anatomic abnormality. Now what is important is that in children, this feeding and swallowing is happening very much hand in hand. Okay? So sometimes this feeding problem leads to a problem in the oral cavity or leads to aspiration. This feeding problem, because the mother is feeding wrongly, the position is wrong, the baby aspirates. And if you just fix some of these things, the aspiration would reduce. Right? So it's very important for us to look at both feeding and swallowing together and try and look at it together always. Next slide. So this gives you the definition of what is a swallowing disorder or dysphagia. Difficulty eating as a result of physiological or anatomical abnormality. We say when there is a difficulty in the anatomy or the physiology. And feeding is more a broader term, where a child will be having difficulty in accepting different kinds of textures and age-appropriate diet. This is very, very important. So if the child is, as I said, 12 months I said, 12 to 18 months I said, when they should be able to eat all consistencies of food. Right? And then I said, at least by 2 to 3 years, they should be able to self-feed themselves. If this is not happening, then there is definitely a feeding problem. Right? And finally, I'll just take maybe another 5 or 6 minutes to go over some indicators for swallowing. When do you identify these? So we looked at all the conditions, but briefly I'll just tell you the red alerts. When should you suspect that there is a feeding or a swallowing problem? If there is a meal time delay. Anything more than 30 minutes is considered abnormal. Okay? If they say that, I just dread, parents say that I just dread the feeding time. I just panic every time, right? If they say that it's stressful, then there is a problem. If there's any kind of respiratory stress that you see during feeding, definitely a problem. This could indicate a pharyngeal phase problem. Rapid breathing, gurgly voice, nasal congestion that increases, panting, any kind of this problem will indicate likely a pharyngeal phase kind of a difficulty. The child has not gained weight. This they will all tell you. Mostly parents will tell you. They will go to the doctor and they'll say not gaining weight, not gaining weight. But some of these things are what we have to really ask. Okay? Not gained weight for the past 2 to 3 months and not able to eat independently. This is something that I insist we ask. We should ask whether they are able to eat independently as per their age. Next slide. Next. Okay, so all of these are other red signs. If there is slow feeding, limited volume of feeding, there's persistent drooling, there's apparent food aversion, that means some food they just don't like or they like only one kind of food. If there is difficulty in transitioning, so he is continuing to be on bottle feed for a long time, they are not transitioning to solid feed, any kind of transition problem will indicate. These are other things, right? So these are other things that you may observe during the feeding. If you observe feeding of the child, you may see that the child is not giving hunger signals, child has poor oral skills, lip closure is poor, there is poor bolus collection, there is insufficient, not chewing enough, all this will indicate to you. So this signs and symptoms are very easy to find out. All you have to do is just observe a feeding. So I think the point I'm trying to make is every child that you're seeing in therapy or diagnostics, right? Definitely, I think we must ask about feeding and swallowing. It's like, okay, so we must ask about feeding and swallowing. So I told you about oral phase, pharyngeal phase, and esophageal phase of swallowing. So I'll just present these symptoms in the next 3 slides about oral, pharyngeal, and esophageal. So all of these symptoms which are in the oral phase will indicate an oral phase kind of a problem. So if the food falls out of the mouth, which you saw in the video, where the child is pouring, mother is pouring the rice kanji and it was all falling out. Difficulty in feeding from the cup, spoon, any method, right? Lack of tongue action to make the bolus. So that child who was eating that dry rice was not really doing any tongue movement to make a bolus. When he opened the mouth also you saw that dry rice in the mouth, right? He was not using the tongue to nicely make a bolus. Pooling of food in the cavities. We saw in the child there was rice left in the mouth even after holding it for some time. There was lack of chewing. Their food is pushed outside the mouth by tongue thrusting. There's slow bolus formation. There's delayed swallow, there's lack of tongue movement for cleaning the teeth. All of this will indicate an oral phase kind of a problem, which you can observe by looking at the baby. If it's a pharyngeal phase problem, I said that if you have a gurgly voice quality, when you see the baby crying or making some sound, and if you see a gurgliness, then it indicates that the food or the liquid has entered into the laryngeal cavity below the level of the vocal folds. That's why the vocal folds, when they move, they create a gurgly voice. So gurgly voice will indicate that likely the child is aspirated. Coughing, of course, very clearly you know that there is a problem. If it's an esophageal phase problem, the child will typically have reflux and frequently vomit. This happens even in the NICU. We see babies who vomit a lot. Next slide. So feeding and swallowing, right, is an interaction of all this. I really like this slide made by these guys because there are child factors, there are structure factors, physiological function factors. These two only are referred to when we refer to swallowing, but there are so many other factors that lead to feeding and swallowing problems. So the culture, the food type, food presentation, the family support, what kind of a family there is, the background, all of that will dictate what food you got. So, different families have different preferences. These are all good things. So, not necessarily bad things, but it's important to get into all of these factors when we think about feeding and swallowing factors. So when we ask, why did you give that? This is what we gave, this is what my mother-in-law said, this is what my mother said. There will be many things like that that are specific to family. So all of these need to be thought of. And this is very, very important. Prior feeding experience, how the baby was fed before will influence how the baby is eating now. So that's why we take a lot of history. We ask, were you in the hospital for a long time? Did you have a tube for some time? These things also matter. Next slide. Okay, so this is the child I showed you, right? These two videos you saw, this was during assessment and therapy at the age of 1 year, 3 months. This child was really far from us. They only stayed with us for demonstration therapy, and by 2 years, 10 months of age, this child was eating, this was the only consistency the child was having, and now the child was having idli, apple, everything. See, now you see much better movements in the child.